McCannual. I'm the BSOT Clinical Manager. As you just heard, you will be recorded for today's session. Today's session is working with family caregivers in long-term care. So just a little bit to go through in terms of acknowledgement and land acknowledgement. So although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central Region behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land of thousands of years. Including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the dish with one spoon wampum, an agreement to peacefully share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. I would like to review some participation guidelines. The session is being recorded, as you heard, and will be archived on Ontario's CLRI and BSO websites. Your microphone is automatically muted. We will have 40 minutes of presentation followed by about 15 minutes of discussion and wrap up. Please place any questions you have in the Q&A or chat box. If you have questions related to tech support, please message Agnes. So you'll see Agnes is listed as telehealth. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form that you'll receive at the end. So our presenter today is Courtney Edmond. Just some background on her. So Courtney is a registered social worker and holds a Bachelor of Social Work with a minor in psychology from Toronto Metropolitan University, formerly Ryerson University. Courtney currently holds the role of social worker as the BSO Caregiver Specialist for long-term care led at the Alzheimer Society of Toronto. Her experience and expertise, including supporting caregivers through navigation of the healthcare system and their loved ones' transition and journey with long-term care. I'm excited to have Courtney on for today. I know her well through BSO, so welcome, Courtney. And I'm going to stop sharing and allow you to do your sharing now.
Thanks, Cara. I'm just going to share my screen now. Okay. So what I will be presenting on today will be the topic of working with family caregivers in long-term care. Just before we get started on the presentation, I did just want to go through the faculty presenter disclosure slides. Something that I did want to disclose prior to beginning the presentation, though, as some of you may know, before my time at the Alzheimer Society of Toronto, I did hold previous employment at the Rakai Centres as a resident and family services coordinator, and a great deal of my experience and knowledge on today's topic was gained during my time in that role and at that organization. Okay, so in terms of the learning objectives that we're going to focus on for today's presentation, so at the end of the presentation, you will be able to identify family caregiver experiences with the long-term care placement. You will be able to better understand family relationships, and you will also be able to identify successful supportive communication skills and strategies. So to start us off for today's presentation, I just wanted to pose this question for you to answer in the chat. If you can just type a quick answer on what are your experiences with family concerns in long-term care. I'll give you about a minute or so to just type any feedback you might have. Okay, hesitancy to begin antipsychotic medications. Yep, that's definitely one that's been prevalent. Concerns that residents are not getting adequate care, unrealistic expectations, concerns about safety, that families don't disclose when there is a substance use issue, for example, alcohol or smoking, because they don't want to get turned down for admission. Family member would say, my mom did not have lunch today, unclear expectations, a mismatch between expectations from families and care team. So a lot of these are definitely very relevant and very prevalent. So for example, as it's been stated in the chat, when families are struggling with admissions to long-term care, they may misplace their anger, frustrations onto staff. At times, it may feel like no matter how much you do to accommodate the requests, it is never enough. They are always there and observe what you do, how long it takes you to respond to call bells and assist anyone and everyone on the floor. Another thing that hadn't been noted that sometimes might occur is they might request daily or sometimes constantly that changes are made to the care plan, even though they were the ones to help create it. They might also openly display hostility towards staff members and regularly cite the Long-Term Care Act or threaten to call the ministry. They might also overreact to instructions from staff members, visit 2 or 3 times per day and during off hours. They might also insist on new or unusual treatments. What was noted in the chat, they might also decline offered non-pharmacological and pharmacological approaches. They might also have numerous and endless complaints. They might also keep a diary or photo album with the facility. They might also install cameras in the resident's room. And they might also expect or demand preferential treatment. Okay, so now we're going to talk a little bit about what our family experience is in long-term care. So from the family perspective, an admission to long-term care can evoke many emotions and fears. For some families, admission to long-term care can be a traumatic experience. So families experience many losses, anxieties, and guilt for abandoning the person. They can struggle with the transition, which can sometimes be a major change in their relationship, in their life, in their daily routine. Many families feel incompetent that they are not providing care at home for the person, especially if that was the expectation before this. They may also let go of their role and accept other care providers. They may also be uncomfortable with the reality of shifting relationships that come with involuntary separation. Contacts and staff and management from the time of admission should lay the foundation for a positive long-term relationship going forward, and they should recognize their value of the family member as someone who knows the resident best. It's important to know that there is in-house transition support available through my role and external BSOT team members to help the family members and the resident feel comfortable and support them through this time. In order to help support with the transition, it's important to introduce yourself and warmly welcome all family members and friends to the long-term care facility. So these are just some stats on caregivers' perspectives on caregiving. These stats do come from the Change Foundation's report, which is called the Spotlight Ontario's Caregivers. It was published in November of 2019, so it was prior to COVID, but there were a lot of stats in this particular report that did resonate quite well with today's topic. So here are just some of the stats that were a part of the report. So the report found that more than half of caregivers found the transition between long-term care homes and or hospital from home to be a difficult one. 40% of caregivers felt they needed emotional support and counseling for themselves. However, only 37% actually received help. Less than 25% felt that they could approach a professional healthcare provider. The majority consulted other family members or friends or the internet. 3 out of 5 reported that they had no choice in taking on their role as a caregiver, and only 1 out of 5 felt that they were coping well in every aspect of their life since taking on the role. So let's just think about these stats for a few moments. As many of you can imagine, I can only imagine that these stats and numbers have likely increased since the time of the pandemic. As we know, the pandemic and the restrictions and when a home is outbreak has caused the experience to be more traumatic. For instance, some folks, when there is a lockdown or homes do have restrictions around visiting, a loved one may not be able to tour the facility that their loved one is being put on the wait list or is accepted to prior to admission. If a home is experiencing a suspected outbreak on a unit at the home and is still able to take admissions at the time of that individual's date of admission, the family member might not be allowed into the facility with them, or the individual might have to be placed on lockdown and isolation for a period of time as well, which contributes to some of the anxiety and worry and stress that happens upon a transition to a long-term care home for many family members. For many caregivers as well, they don't have support available, or they don't know where to turn to, or don't know how to access that support. And that's where my role and other folks at the Alzheimer Society of Toronto can come in handy. I will be dropping my contacts information at the end of the presentation. So when in doubt, if there is anyone you feel might benefit from my support, or you would just like to consult about a particular situation, you're welcome to reach out to me at any point in time, and I hope I can help be of assistance to you. Okay, so now we're just going to talk a little bit about types of complex family relationships, because as we know, there are many different family relationships we see within long-term care home setting. So in addition to family experiences, we need to understand the complexity that comes with any family relationship. So you might find there are enmeshed relationships, and these are relationships that are driven by intense emotions, overprotectiveness, over-involvement in care, and unrealistic expectations. They might also have insistence on overly aggressive care. Then there are also family members who are disengaged. So these might be folks that are emotionally distant, difficult to reach, which limits care, or they do not respond to your phone calls or messages. In some families, there may also be family hierarchies present. So this might be where there is a family leader, a quote unquote individual who's seen as a health expert, someone who sees suggestions from staff as a challenge to their authority. For example, in some cultures, this might fall on the eldest sibling, child, or family member. There might also be a triangulation in the family that occurs when two siblings do not get along, but are able to unite to express their dissatisfaction with the staff. You might also see a collation present when family members take sides against other family members. You as staff must be careful not to take sides, even if you do agree with one particular side, because by taking sides, you may entangle yourself in the family conflict, which in turn can lead to further distrust. As a team, when you become aware of family conflict, it's important to meet with the entire family to provide objective information and encourage them to discuss their differences to have the best outcome for the person. It's also important to make sure to provide information or refer them to my support through the Caregiver Specialist Program. As many of you have been involved and connected to my support, you know this can be helpful when there are some complex family relationships present. Knowing and understanding these patterns are always beneficial for staff. In a huddle and as often as needed, you should discuss and remind yourselves what makes this particular family difficult to work with collaboratively. And from there, you can then tailor your approach so everyone, including the family, feels comfortable with the transition to long-term care. Okay, so now we're going to talk a little bit about what influences interactions. So something that may influence interactions is staff assumption about the family culture, gender, age, and knowledge of healthcare. So even if a family has a similar culture to your own, there are cultures within the cultures. There can be differences in personal experiences and in influences. Another factor that might influence interactions is a family's ability to understand the information presented to them. So all of these factors affect how the care partner hears the information you tell them and how it will affect the decisions they make. Family could be labeled difficult because they don't understand, misinterpret information presented to them, or their value system differs from the dominant culture within the home. So that's when it falls back on a lack of shared understanding between families and staff of the nature of their concerns. This can be shown, for example, when it comes to palliative care in some cultures, as some cultures will save a resident at all costs and they will refuse to consider any end-of-life decisions or care planning. Some cultures may be more familiar to the staff and other residents because they belong to the same culture, and cultural differences can result in a misunderstanding and conflict between staff and families and care partners. A person-centered approach with family care partners can help in guiding your conversations this way. It's important that staff are open to learning about the culture and the values of the resident and his or her family. And it's also important to clarify with the family that they understood the information shared with them. Using the SBAR model can be helpful when trying to help identify the specific concerns in a situation. So I'm just going to open the chat box again to a particular scenario question. Just going to read it out, and I want you to respond with how this would make you feel. So the scenario in this particular situation is that you had seen your doctor 2 weeks ago and did some medical tests, including blood work. You missed a phone call from the doctor's office during your shift, and you check your voicemail during your break. The message states for you to please call us back at your earliest opportunity. You call and are informed that the office is closed for the long weekend. How would this make you feel? Yep. So worried, anxious, frustrated. Okay, I'll just give it another moment or so. Anxiety, couldn't sleep, squirrel. Okay, so yeah, those responses are all very valid, and that's that's likely what I would be feeling in that scenario as well. Some that weren't stated would be concerned, um, stressed, and that you want to make sure it's not an emergency because you're wondering what they're calling about. And oftentimes, I know a preconception is that no news is good news. So there is that um, worry that comes with receiving a phone call after a doctor's visit. So the common theme with some of these responses that were provided in the chat and that I just shared are lack of details. So lack of details can be upsetting, and not being able to connect with someone until a few days later can be upsetting. Like I said, the assumption of no news is good news. So if they're calling, we automatically assume that something is wrong. Okay, so now I'm going to ask again in the chat for what you think communication is. So what is communication to you? A two-way conversation, verbal and nonverbal cues to indicate a need, getting a message across, open, honest dialogue, open to listen and absorb, feedback or giving information to someone, sending information and receiving information, getting a message across, channel of information, verbal and nonverbal cues, two-way means of giving a message in to indicate a need. Okay, these are all great answers, but what I have come up with is the following. So communication is more than an exchange of information. So it's sending and receiving information. It involves understanding and interpreting information, and it helps us relate to others, communicate what our needs, wishes, opinions, and thoughts may need. So we may tend to focus our discussions about communication on interactions with our residents, but communication happens all the time with many people, fellow team members, families, care providers, healthcare providers, in our personal and professional lives. So we should always be mindful of our communication, both verbally and non-verbally. So I just want you to think about these messages I'm going to read out to you. And I want you to respond back in the chat if these sound like typical calls that you have made or may make to family or care partners. So the first message is the doctor wants to increase the meds. The second message is your dad pulled down his pants again today. The third message is your mom hit the staff during care again today. And the fourth message is your mom fell today. Do these sound like typical messages you might relay to family members? Someone said, unfortunately, yes. These are typical messages that the family receives. So yes, frequently. Okay. Not using this language, but yes, but with 5 W's explained. So yeah, these are often phone calls that staff within long-term care homes typically make to family members, depending on what occurs with their loved ones. In terms of what family or care partners are concerned about with these messages is what is happening to their loved one and how much information they will get. So no one wants to feel ignored or left in the dark. Oftentimes, complaints are raised about information or lack thereof. Families feel the helplessness of losing control of the resident's care and the frustration of not being able to provide the care themselves, as well as ease their loved one's pain. What their role is and how they can help, families want guidance as to how best to be involved. So, not feeling listened to and that their concerns are not being taken seriously can have a significant impact on the relationship and communication interactions going forward. So here are some elements of good communication. So during communication with family members within long-term care, it's important to set the purpose of the goal of the conversation. So an example of this might be by saying, I'm calling to keep you informed. There was a situation where your dad pulled down his pants again today, versus just stating that your dad pulled his pants down again today. Should also be prepared in these instances to talk about what the staff did in the situation to help provide reassurance to the family. Even if the situation does remain unresolved, reassuring them that staff are continuing to assess and find strategies and interventions can go a long way. It's also important to involve the family member and ask if they have any recommendations or insights. It's important to also display active listening and to also clarify by repeating back what their concerns are when they do raise a concern to you to ensure that you have a shared understanding of the situation. It's also important to display empathy. So once the staff understands what is causing the family stress, he or she is in a better position to offer help. It's important to be mindful of what you say and how you say it. For example, saying your dad pulled down his pants again today versus I'm calling to keep you informed. There was a situation where your dad pulled down his pants again today. So like I said before, setting the goal and purpose of the conversation and being clear and concise can go a long way. Another thing that is important is that transparency is key through consistent communication. So the rest of the bullet points are all ideas of how you can support the team's responses to caregivers. For example, a few homes during the pandemic did implement the idea of a weekly e-bulletin or memo that was sent out to family members during the first wave of the pandemic, and I know quite a few have continued this on. Although the news was difficult at times for families to hear about the situation, of the virus in the home. They did respond well to newsletters like these because they felt as though they were being informed of new developments and outcomes, whether the information shared was good or bad. All of these different elements of communication will help to build trust, rapport, and relationships. And this will also help the issue of mistrust, which over the long run should help with less family interference and less family anxiety. Lastly, it's important to know that you can redirect to the most appropriate person when needed. You are a part of a team and you can always call on other team members when needed and when appropriate. Okay, so these are just ways to ensure open and honest communication. Open and honest communication with the family will go a long way in establishing positive family relationships with the facility. So it's important to respond to family inquiries with specific and relevant information, to center conversations on the needs of the resident, and to assure the family that staff are there to help. So these are just some tactics on how to respond to family questions. So if a family asks a specific question, it can be helpful to ask more specific questions to better understand what their concerns or questions are. If a family asks a question you don't know the answer to, you can find the staff who can answer the question. So this doesn't necessarily mean you're dropping everything you're doing in the moment to go and find the person that can best answer that question, but it might instead mean that you are writing down to follow up later, directing the person to the staff who can best answer the question. So for example, letting them know where the social worker's office is located and who that individual is, or even finding the charge nurse who is on duty. It's important to never leave a family member without a plan to obtain the answers to his or her questions, and know that staff should recur complex inquiries to their supervisors. If complex inquiries do happen to occur during evening shifts when certain supervisors are not in the home, it's important to have staff members ask the family member to write down his or her name and phone number, as well as the nature of their question. It's important to also ensure the family member that they will follow up within a reasonable time frame. And it's important to also remember to give the family member your undivided attention and to give time to respond. Like I said before, be mindful of your nonverbal cues and body language, and make sure we are presenting active listening skills. Okay, when responding to an upset family member, a helpful approach to take is taking the heat. So that is firstly, H is to hear the person out. So to let them speak uninterrupted and listen with respect. Often after 2 minutes, people will start to calm down and will have had the opportunity to say what is on their mind. You can also repeat back to ensure you understood their concerns. E is to emphasize. So to echo the source of their frustration and show you are trying to understand their position and situation and point of view. So for example, you could state, I imagine I would be upset too if I were in your situation. This is how we validate their experience. A is to apologize. So even if you are not at fault, you acknowledge their distress and experience of being upset. When someone has lost a loved one, we say, I'm so sorry for your loss. Even though this loss is not caused by you, we're still sharing our empathy. And lastly, T is to take responsibility for action. So the action can be small. For example, it can be listening to the person and giving them the contact information of someone who is able to help them, or even gently reminding them of the process to do this. Okay, so going in more depth on each letter of the HEAT model. So H, hear them out. So you can establish rapport with someone, especially someone who may be angry with the admission. It's not an easy task to do this, but by hearing them out, you can let them talk and simply listen to what they have to say without jumping to offer up a solution. This is not always easy to do, especially when a family caregiver is venting, but when the person feels heard and valued, you'll find they are much more open to solutions. They feel better and emotions get set aside, which opens the door for communication both ways. In summary, you should listen to understand, do not interrupt, mind your body language, focus on the issue, and not take the person. You should also take notes, summary, and clarify the issues, and not focus on the person, but focus on the issue. So E for empathize. It's important to connect and invest in building a trusting relationship with family and care partners, especially those who are struggling with admission to a long-term care home. So it's important to be open, transparent, and honest in what you have to say. Engage with same level of emotion as the family care partner to indicate empathy. If you respond with sympathy, you will feel worn out and emotionally drained at the end of the day. The key is to be aware and to be sensitive to the family care partner without becoming emotionally involved with them. Responding with empathy will enable you to stay calm and in control, as well as professional. It's important that you do not try to suggest solutions to the problem before you have dealt with the person's emotions. It can be a mistake, as they will not be willing to listen to your suggestions or be open to different approaches or interventions. And A for apologize. So apologizing is another way of connecting with the person. Offering a sincere apology does not admit blame. It rather establishes a trusting connection. Even if you were not personally responsible, it is an acknowledgement that things aren't going well. To ensure apologies are genuine and personal, you can use I statements. So for example, I'm sorry that you have been kept waiting, or I'm sorry this has bothered or upset you today. It's important to know that a timely apology is better, and apologizing helps to put the person at ease and also indicates your willingness to help. A genuine apology can diffuse the situation. For example, I'm so sorry we are unable to do that. However, we may be able to do blank and include it in his care plan. So an example of this could be when it comes to showering. You could share that you can't give them a shower every day, but you will make sure that they get a shower on Sundays and Wednesdays when they want to go to a church service in the community. Okay, and lastly, T is to take action. So it's important to make sure to have an action plan or solution ready. It is important for the person to know that you are willing and able to help. Taking action will make a huge difference to the person you are dealing with and will build your credibility. By letting them know you will take action to resolve the issue, you will be on your way to restoring their confidence. You can do the following to demonstrate ownership. Time is always a critical factor, and your ability to be responsive is more important than ever. It's important to follow up after an issue, even if briefly, to ensure the problem has been resolved or is being looked into. It's important to be proactive in raising issues that are affecting the person as well. And your ability to ultimately resolve the situation does restore trust in the relationship and trust in the family member, in the home's relationship and support. Okay, so I'm just going to ask in the chat box again, what are some ways that you have built rapport with family members? So family members of residents in the long-term care home. Providing an ear to listen, calling them before admission to offer to or answer questions, ask them to share stories of their family member, asking about their family member who has moved in, getting to know them. Being honest, kind, understanding, and bouncing back what they've said to you. I've reported positive events. Yeah, so these are all great ways to build rapport with family members. So some other things noted that weren't in the chat are having regular conversations with them. So whether that be providing updates regarding how the resident is eating, socializing, and mobilizing. It could be sharing photos of them engaging in an activity at the home if the family member is maybe long distance caregiving and is not regularly visiting the home as well. You can also develop rapport by acknowledging family members, checking in with them about how they're doing as well. As we learned through this presentation, there are a lot of emotions and feelings that family members are going when it comes to a move to long-term care, as well as the changes that they may see in their loved one through the progression of dementia and other health conditions. It's important to also show warmth and concern in order to develop rapport and to take a team approach. So by taking a team approach, that's having a shared understanding and being consistent in order to build trust. So something that some homes have done is they have photos of the staff on the floor or in the elevator area going up to all of the floors that have photos of the staff, their name, and a little bit of a description of them or a little bit about them. This just helps family members get a little bit more acquainted and informed of who is caring for their loved one. Okay, we're going to talk a little bit now about the role of management in supporting interactions. So when a complaint is made by the family, management does have a responsibility to listen to the concerns of the family. In order to diffuse conflicts with families, it's important to establish an open, honest, and respectful communication environment. As we all know, family members watch and listen to everything going on and make their own assumptions. Their first impressions of the home are important. An in-home transition team does help family members to adjust to their new environment. So like I said, upon those first couple weeks after admission or even couple days, if you do notice that a family member is having a little bit of difficulty coping with the transition, you're welcome to reach out to me at any point in time and refer them for my support. And if there are any healthcare professionals on the webinar that work with folks prior to admission to long-term care. So whether you're supporting folks in the community or supporting folks in acute care or primary care, you're welcome to also refer them to my support, and I can help with the transition prior to them moving into long-term care as well. Something that's also important to do is to invite families into the home and embrace them as part of the team, as I've shared many times throughout this presentation before, because this does lay the foundation for a positive long-term working relationship. This warm process communicates to the family that they are valued. And for management, it is an opportunity to tell the family and care partners about the facility and what they can realistically expect going forward. So setting those clear boundaries and expectations is key. And any complaints that arise between the family and care partners and staff, it is equally important for the management to understand the staff perspective. So remember to consider the feedback and communication. If management has had a discussion with the family regarding concerns, do you know the outcome of those discussions? It's important to be kept in the loop so you ensure that you're giving the appropriate message to family members moving forward. Okay, so our takeaway from today's presentation is that local caregivers are here to stay. Since the pandemic, caregivers are even more aware of what to expect in terms of their care for their person. The more we provide these families with information upfront and respond in a thoughtful and responsive way and be completely transparent, the more you are likely to be successful working with these families. It's important to also focus on ways to help these families from the very beginning and embrace them as an important part of the care team. Another takeaway is that we need to find ways for caregivers, staff, and management to all work together for the best outcome for the resident. And like I said many times throughout this presentation, don't forget you have myself as a community partner who can assist you with any family or care partner concerns. Okay, these are just some of today's references. And now we're going to move into any questions or comments you might have.
Thanks so much, Courtney. This was great. So now is your opportunity to use and abuse Courtney and her knowledge. As you can hear, she's a strong clinician and very experienced in this area. So please use the chat box or Q&A if you do have questions. If you feel that you have a question that you would rather speak to, we also have the ability to unmute you, so you can let us know if you wanted to contribute that way. So one question coming through, does a person need a diagnosis of dementia for them to be referred to your services?
Yeah, no, that is a great question. So they do need to be living with a form of cognitive impairment. It doesn't necessarily have to be dementia. It can be suspected, but they do need to be living with a form of cognitive impairment.
And are you available for palliative care?
So I can certainly help support with palliative care in terms of if the family is requiring some support and education in that area. Depending on when I do become connected to the caregiver and my collaboration with the team, I might be able to support through end of life care meetings or care conferences as well.
Are there multiple BSO caregiver specialists? How many homes does Courtney typically support?
Yeah, so there is only one BSO caregiver specialist for long-term care. I do have a counterpart named Carolyn Eplett, though she does work with folks in the Toronto Central region on the community side. I do support all of the homes in the Toronto Central region, but I do also support caregivers who may have a loved one at another home in the M postal code. So if there is a caregiver caring for someone who lives at a home in Central region, Central East, Central West, I can also support them with that as well.
And Marilyn asks, when there is high risk to harm other residents, how do you approach this when tough decisions need to be made?
Yeah, that is a challenging one to answer. I would say it's subject to situation. I would say if there are any long-term care BSO leads that are having any challenges with this, definitely reach out to me. I'm always open to consult with BSO leads on situations before a referral is made. So sometimes I can support from afar as well. So if there is ever a situation that you're unsure about or where there is a risk of harm present, please do not hesitate to reach out to me because I can definitely help support.
Perfect. And I did see a question, but it went away. It was about if you have any information on PICA and dementia. It went away.
Sorry, what was that question again, Cara?
It's okay. Do you know if there's any information available on PICA, P-I-C-A, and dementia through Alzheimer's?
Sorry, I'm not familiar with the PICA acronym. Do you?
If Yvonne can comment there. Another comment, so Iris says, BSO can be burnt out. Would you be a good support for BSO?
Yeah, so something that I can also do is collaborate with other departments and members of the Alzheimer's Society of Toronto team. So our public education department does offer a variety of different educations and trainings and sessions for registered staff within long-term care. I also am able to provide education as well to caregivers and staff. And I also work in collaboration with the PRCs too. So certainly education or some support needed around burnout is something that I could definitely help support with.
And I think I was the one who was mispronouncing. I think it's pica, and it's clients who eat everything. So it could be inedible items as well. So she's asking, do you know if there is any information available about that condition and dementia through Alzheimer's Society?
Yeah, so we do have a lot of written materials and webinars. Yvonne, if maybe you can send me an email, you'll see my email contact details in the next slide following this webinar. I should be able to share some resources with you on these topics.
Great, she says thanks. Any other questions from the group?
Thanks, Ayala.
We'll give it another minute to see if anybody's typing. Okay, so Agnes, can you see? So I think one person would like to speak. Go ahead.
I think it's me, Helena. Okay, I have a question. I have the situation with a family member that, how to say, like her mom, she has dementia, but she doesn't have any responsive behaviors. So the family member doesn't understand that there are other residents might present with these responsive behaviors, and sometimes it takes time to find approaches or adjust the medication. And, a few times we had, so families complaining constantly to the management, and they had a few times, including me and the family and the management, we had a discussion. We tried to explain that, we are working, doctors working, and other external resources are involved, but, they don't want to really be like, this explanation. And I was just trying to offer them like, like maybe, I don't know how, actually I was trying to offer them a help from you, but, they said, I don't need this, I don't need this education, so maybe I don't know how to actually bring this to them. So, they are declining this help, so they would say, oh, you better talk to the family member of the resident with responsive behavior, not to me. So, I'm not the one who is, need this education, or like, I don't know how to bring it to family, because we all feel that, they would benefit from that, having this information about responsive behaviors, about, but they feel like, it's very distracting and very to their mom. Maybe suggestion how I can
Yeah, for this particular scenario, I just was going to say maybe we can connect offline about this one. I know we have connected about other family situations at your home in the past. So maybe send me an email and we can maybe try to set up a conversation sometime tomorrow or early next week. How does that sound?
Okay, sounds good, Courtney. Thank you. Thank you so much.
No
Yeah.
problem.
Great. And Marilyn asked, can you comment on sexual relationships, how families respond when the family member is wanting the person not to be with another resident, or if there are inappropriate behaviors?
Yeah, so changes in relationships, changes in sexuality can cause a lot of different emotions for a family member. That's something that we do work with family members around quite a bit at the Alzheimer Society of Toronto. We do have a webinar on sexual intimacy and dementia. We do have a number of reading materials as well. But it is a very common one that does happen when their loved one does admit to long-term care, especially for spouses when they are also dealing with feelings of that involuntary separation and the change in their relationship and intimacy level. So there does come a lot of emotions and feelings with it, and I do work with families quite a bit around it, especially when there are behaviors that weren't displayed prior to their condition or prior to their time in long-term care as well. So there definitely is a lot of different emotions and feelings that family members do go through with that. Yes, I know, Marilyn, it really is.
And Marilyn, I can let you know that we're in the works of preparing some education. So we're starting with one long-term care home to provide some education on this topic exactly. It'll be myself and the PRC and our ethicist at Baycrest. And this is something that we're going to look at sharing with all of the long-term care homes, and then eventually create something that will be available for caregivers and work with Courtney with that.
And when I do talk about those topics with caregivers, I do share some strategies. And many times when there are responsive behaviors present, whether it be sexual, whether it be verbal, whether it be physical, many times I will have some collaboration with the BSO lead too. And I may participate in some joint meetings with the family members as well.
Any other questions for Courtney? Another hand raised. Agnes, if you can help out, it's Marilyn. We'll get you unmuted, Marilyn.
Another question is what do you do when family members are bringing in things that you don't want them to bring in? So alcohol, cigarettes, weed. How do you have those conversations with family members?
Yeah, that's where I think setting those clear expectations from the start can be very helpful. Also, just developing that rapport early on. I know sometimes if the home has their own particular policies in place and these are shared with family members, whether it be an admissions package, whether it be before they're even admitted to the home, that can go a long way as well. There's many different ways to approach it as well. I would say it ultimately also depends how it's addressed, depending on which member of the family is bringing these in, whether it's the power of attorney or whether it's another family member or friend. That can also factor into how this is approached and how it's addressed as well. But I think setting those guidelines from the start can help go a long way.
I think we've had other conversations about what about to the power of attorney's gone bad, that that they're really not making great decisions on behalf of their family member, and they really ought not to be the POA or the SDM. And how to sort of, what's the workaround with that? How do you as much hand holding as you can do with them, and you just at some point there needs to be some decision making that's a little bit better informed, and not because not all caregivers are themselves well.
Yeah, no, absolutely. And that's when I can be very helpful to be brought in, whether that is for me to develop that rapport with that particular person and help bring them to that understanding or realization, or whether it's that consultation from afar as well. I have a wide array of knowledge and resources in the dementia and healthcare realm. So any questions you might have, or like I said, if there's any situations where you're not exactly sure how to tackle and maybe just want some consultation from afar, you can certainly reach out to me at any point in time.
Thanks, Courtney.
No problem.
Any other questions from the group? Otherwise, I think Courtney, you said on the next slide, it has your contact information. Yeah. Just to mention, I know Courtney spoke about her counterpart in the community sector, Carolyn. So right now we have it set up that if Carolyn is required, it is an internal referral. Certainly, if you see that there is a need for a community case that there would be benefit in terms of having a social worker involved, you can speak to the BSOT clinician that's attached to that file, and they can help coordinate that.
Perfect. Well, I guess I'll share my contact information then if there are no other questions. Okay, so these are all of my contact details here. So you're welcome to reach out to me either by phone or email. I would say email is probably better just because I might not always have availability at the time of a call. So just, I would say reaching out over email and scheduling a call with me is probably the best way to go. I'm usually pretty quick to respond to emails, and I have the ability to do so, of course, if I'm in a particular meeting, whereas I wouldn't be able to speak on the phone and respond back that way. So I would say email is probably the best way to get in touch with me, but I am certainly always open to speaking over the phone as well.
Can I ask quickly, Courtney, what's your length of time usually that you're involved with family members?
That's a great question. I would say it really does vary depending on the family caregiver situation. So some families might feel well supported and like they have what they need after one interaction, two interactions, a few interactions. Others, as we know with long-term care, things are changing constantly when it comes to their loved one's condition or situation at the home. So there are some folks where I might stay involved for a period of time and kind of leave it to the family that they can reach out to me at any point in time if support is needed again. Others I might be supporting, everything is settled, and then they'll either reach back out or the BSO leader staff at the home will send me a message asking if I can check in with them. So it really does vary kind of depending on situation. A great deal of my support is either around that initial transition to the home or if there is the exhibition of responsive behaviors. So it really varies depending on situation.
Great. Well, I don't see any other questions coming into the chat on my end. Okay, so I'd like to thank everyone for joining us today. Thank you, of course, to Courtney. This is great information to share. You're a wonderful resource. I wish that there was more of you. Just a quick reminder that if you'd like a certificate of attendance, please complete the brief evaluation survey, which will be emailed to you afterwards. The recording, once again, will be available on the CLRI and BSO websites. And with that, thank you everyone again for joining us and have a wonderful day.
Thank you.